Hello, everyone. I'm Subodh. I'm the Dean of the Royal College of Psychiatrists, and I think it's my pleasure to welcome you all to the latest edition of our Dean's Grand Rounds. People are joining in, so I'll let them join in and I'll give my housekeeping notes in a minute. But those who have just joined in already, feel free to use the chat to type in where you're logging in from. But for questions, please use the Q&A box and not the chat box because we will not be monitoring the chat. A warm welcome to Dr. Manal El Maraghy, who's a consultant psychiatrist in Essex Partnership Trust. Manal, I've known you for a very long time. You've been, we go back a long time. It's a pleasure to be here on the stage with you. So thank you so much for organizing this on behalf of the perinatal faculty. This is such an important topic, neurodiversity in the perinatal period. So this is a really important topic clinically, and it's exciting to have such a learned panel here. Also on the screen is Dr. Deepa Krishnan. Some of you, the regulars on Dean's Grand Rounds will know her, that she is the lead for the Dean's Grand Rounds and has been organizing them so successfully. And today, I believe, I can't see the number right now, but we have almost 800 or 900 people registering. So that's lovely. I'm logging in from Leeds, and where the Psychiatric Trainees Conference is happening, and I think which has also been quite an interesting, good meeting. So lovely to see you all. I'll just quickly go through some housekeeping rules. So as I've said, please feel free to use the chat just to kind of introduce yourself or say hello to people. But any questions for the panelists, please use the Q&A box. We will not be monitoring the chat for questions. If you have any technical questions, please let us know in the chat, and then we'll try and sort it. Obviously, the chat is open and public, so please be civil and courteous, as I'm sure you will all be. If we do notice any inappropriate comments, and we've had this once or twice in the past, we've had to remove those people from the webinar, as you can imagine, which is an appropriate thing to do. And then those comments were deleted. So I'm sure that won't happen today, but just a reminder to make sure to keep our conversations civil and courteous. We'll send you your certificate of attendance within the next week, and you will be sent an email once the recording is available too. Final point from me, I think, just to say that the Dean's Grand Rounds has a specific function. I've set this up to bridge the gap between evidence and practice. And so where we know the evidence is good and solid, often the practice follows many, many years later, 15, 20 years later. And I think this group is really about bridging that gap. And so we have a lived experience story, we have academics providing us with evidence, but I also want you all to think about what does this mean for your community of practice. So when you go back from this grand rounds, please go and have a look at your own area of practice, whichever part of the world you're in. And I can see there are people logging in from all over the world. Wherever you are, please go and see what does this mean for your area of practice, and then try and bridge that gap and narrow the gap. So with that, I'll pass you over to Manal. Thank you so much. Welcome, Manal.
Thank you very much, Subodh. Thank you, everyone who joined in. Thank you for the panelists and for the staff behind the scene to support this fantastic idea of linking division and faculties and work on practical things. So I have pleasure to introduce the next two speakers. So we'll start first by listening to Dr. Sam Porter, who has great interest in neurodiversity in general, and he will give us a talk about the autism in the perinatal period. And to follow from him, Dr. Sam Porter is currently working in London. To follow from him, we will have a talk from Dr. Jessica Gibson, who is working in Oxford. Dr. Gibson is the lead of the ADHD service in Oxfordshire, and she has great experience in perinatal psychiatry, and she is also in general interested in women mental health. So without further ado, I will ask Dr. Porter to please come in and talk to us about autism in the perinatal period. Thank you very much.
Thanks, Manal. Can you see my slides? Okay, there's a,
Yes, very clear. Thank you.
So, and thanks for inviting me to speak today. I'm Sam Porter. I'm a consultant perinatal psychiatrist. My area of particular sort of clinical interest is autism in the perinatal period, which is what I'm going to be talking about to you today. Oh, what's going on? Right. So just a little overview. I'm going to sort of talk about autism and the relationship between autism and mental health, and specifically women's mental health, just to sort of try and set a case for why autism is an essential part of perinatal psychiatry. And then I'm going to take you through the perinatal journey from an autistic perspective. Just as a brief refresher before I begin, autism has a prevalence of about 2.5%, male to female ratio of 2 to 3 to 1. About a third of autistic people have an intellectual disability. And it's characterized by significant differences in social communication, styles and preferences, and restricted and repetitive behaviors and interests. And the diagnosis requires these significant differences to be present across all 3 social communication domains and at least 2 of the RRBI domains. Now, autism and association with mental illness. Autistic people are more likely to see psychiatrists than non-autistic people. They've got higher rates of all of these conditions that you can see on the screen, and perhaps, the most stark one being autistic people are about 7 times more likely to complete suicide than non-autistic people. As well as autistic people seeing more psychiatrists than non-autistic people, psychiatrists see a lot of autistic people. And a study in Sweden that screened and, where indicated, assessed every single patient who was referred to an outpatient department over just that period of time. About 20% of them were autistic. Now, there are certain risk factors for autistic people for developing mental health problems. One of them is a late diagnosis, and late diagnosis is associated with higher rates of all mental illnesses except schizophrenia. Schizophrenia is completely unaffected by the age of diagnosis, which makes sense. We also know, and this is probably very linked to this, that autistic people who have high levels of masking or camouflaging tend to have worse mental health outcomes. Now, where this becomes particularly relevant for perinatal psychiatry is that women are typically diagnosed later, and women typically mask more. So we might expect that female autistics might particularly have problems with their mental health, and the evidence bears this out. Autistic women have higher rates of mental health diagnosis, hospitalization, but most, perhaps sort of importantly, death in hospital during hospital admissions and suicide. Not only do they have higher rates of these than non-autistic women, but also than autistic men. And autistic people are one of the few demographic groups where being female is a risk factor for completing suicide. Autistic women also have high levels of misdiagnosis, and misdiagnosis, EPD, is a very common misdiagnosis, but about up to 80% of autistic women will be diagnosed with a psychiatric condition before they get diagnosed with autism. And it doesn't get much better when we start thinking about their perinatal health, as well as perinatal psychiatry and high rates of antenatal and postnatal depression. There are high rates of adverse obstetric outcomes for autistic women. And when in recent years there's been studies that have shown that being born by C-section or being born prematurely is a risk factor for being autistic, that was not a surprise to me, because we already had the evidence that autistic women were more likely to have cesareans and more likely to have premature deliveries. And autistic women are the biggest cause of autistic babies in the world. Now, I'm going to take you through the perinatal journey and just think about things from an autistic perspective and sort of some of the challenges that autistic women may face, for 2 reasons. One, to help you if you see your patients, your autistic patients, sort of to help them to preempt and avoid some of these challenges. But also, if you are seeing patients who are having these challenges, to question whether or not they might be autistic. Now, nothing is unique or ubiquitous. I'm not saying that if somebody has one of these challenges that I'm going to describe that they must be autistic. but it's just something to bear in mind. And the sort of illustration I use is left-handedness is an autistic trait. Insofar as left-handed people are about 2.5 times more likely to be autistic, and autistic people are about 3 times more likely to be left-handed. However, most autistic people are right-handed, most left-handed people aren't autistic, but it's an autistic trait. I wouldn't suspect a patient was autistic just on the grounds that she was left-handed. But if there were a few other clues from the history, and then I noticed that she was left-handed, it might prompt me to consider screening her. So going through this journey then, starting with conception, where, I know there are alternatives now, but the traditional method remains popular. And autistic people have sex, they have, relationships, marriages, babies. That's where autistic people come from, autistic people having sex. So someone being in a relationship, having a baby, does not go against them being autistic. Autistic people in studies are almost as likely to be having sex as non-autistic people, but interestingly get STDs at the same rate, so potentially engaging in slightly riskier sexual activity. Autistic women have higher rates of endometriosis and polycystic ovaries. Again, that's kind of like a left-handedness kind of, if I'm already thinking about it and they say they've got endometriosis, it's just another little thing to prompt exploration. But that means that autistic women, may have some issues conceiving. Conception can also become a mini little special interest. So if you see a patient and she's talking about how, she was there with the thermometers and the calendars, and, I had one patient who sounded like induced erectile dysfunction in her husband by giving him a 12-minute ejaculation window whilst he was chopping some vegetables. If you see women where the sort of conceiving has become a very dominant sort of almost monotypic focus, just wonder. Antenatal care is where we meet most of our autistic patients in perinatal psychiatry, or most of our patients, sorry. And just imagine that you're someone who struggles with meeting new people, disruptions to your routine, navigating to unfamiliar places, uncertainty. Receiving standard antenatal care can become quite overwhelming. If you've got autistic patients, really advocate to keep things as consistent as possible for them, seeing the same people in the same places. If they can have appointments at the same day at the same time where possible, just keeping things as consistent as you can. If there are patients where there are concerns that they're missing lots of appointments, especially if they're sort of cancelling on the morning with a different excuse each time, or there's safeguarding concerns because they've missed a sort of threshold number of appointments, just ask yourself if they might be autistic. Think about the sensory environment as well. In your clinical space, antenatal clinic rooms are often very, very bright. And I remember I had a patient that I was asked to see. The obstetrician had seen her one week and thought she was very depressed. And, a midwife had seen her another week, and our nurse had seen her, and they all thought she was very depressed, but she absolutely denied being depressed and refused any interventions. And so they asked me to see her. And she was there, hunched, looking at the ground, one-word answers, saying, no, I'm not depressed, but, very much giving an objective feel of a depressed person. But there'd been a few clues from her background history that perhaps she might have been autistic. And I had noticed that she'd tried to look up a couple of times, but then had sort of put her head back down. And I asked her, I said, would you like me to turn the lights off? And she seemed a bit surprised by the offer, but very grateful. And within a few minutes, we were having a back and forth conversation. She wasn't depressed. She was just so overwhelmed by the brightness of the room that she couldn't think. And so just think about your sensory environment, because she was autistic. If we'd have assessed her and she hadn't quite met the criteria, it would have still been the right thing to do to turn the light off in the room So just think about the sensory environment of your clinic room with each patient that you see, whether they're autistic or not. Nobody will be harmed by being offered a choice of how well lit it is or whether the window's open or not. If it's just something you offer to everyone, then you won't miss any undiagnosed people. And also just think about, with regard to antenatal care, imagine being somebody who is prone to anxiety, struggles with vagueness, has a very keen sense of pattern recognition, and is hypersensitive when it comes to interoception. And then they get told, come in if you notice any change in your baby's movements. They could end up coming in quite a lot. And the sort of, when I think of the 2 or 3 patients over the years where it's been, they've been coming in multiple times each week, worried about their baby's movements, that they have all been autistic. Now, I'm not saying this would only happen to autistic people, but I think if somebody is coming in all the time worried about fetal movements, it's definitely something that you should be very proactively considering. Moving on to labour, I've had 2 patients, autistic patients, who've told me that they did not think that any stage of labour was painful. One of them said uncomfortable would be a better word. Neither of them used any analgesia. They, like some autistic people, are hyposensitive to pain. None of them were forced to take pethidine. None of them were told to start screaming. None of them were told that they were wrong for not being in enough pain for the stage of labour that they're in. However, patients who are hypersensitive to pain do get shamed for that. They do get denied analgesia because the stage of labour is not, something that should require that much analgesia. I have seen a woman who was kneeling on the floor, bent over, crying, that she should wait for the real pain to start before she had analgesia. We should be advocating, not just for autistic patients, but for patients in general, for them to be treated according to the pain that they're perceiving, not what somebody over the phone or in a clinic in front of them thinks they should be perceiving at that stage of labour. Also, autistic people might have different ways of communicating pain. Some autistic people laugh when they're in pain. Some autistic people will shut down and be unable to say that they're in pain, and they won't look like they're in pain. So it's really helpful ahead of time to think with your autistic patients, how do you normally respond to pain? How do you want us to approach you? Just think about how they will be able to communicate that they want pain relief if they are unable to talk. I think just birth planning in general is really helpful for autistic patients, but this is really an important area to focus on. Think about postnatal care, minimize the time on the ward. Maybe they've been taking sertraline, but does the baby really, really need to stay in for 48, 72 hours? Probably not. She can bring it back if she's really worried, but having an autistic person in a strange environment with lots of sensory overwhelm, with a brand new baby while they're in pain, they're tired and everything else, it's just a recipe for disaster, and I've seen it go disastrously a few times. Given the side room if possible, and just generally accepting idiosyncrasy. I had a patient who was in a mother and baby assessment unit, and they were very unhappy with the way she changed a nappy, because the way she changed the nappy, occasionally the baby's heel would get a bit of feces on it. And I said to them, does the baby end the process completely clean and in a dry nappy and, not pulled about in any painful directions? And they said yes. And I said, well, then why does it matter if she does it your way or not? But, the sort of irony of the rigidness. But, autistic people will often really struggle to do things in ways that are not their idiosyncratic way. And, if the outcome is the same, just let them do that and give them permission to be autistic. I had a patient who has never slept without a dummy, except after she'd given birth to babies. She said that, you know, when she was a young lady and might go home with a man, she would wait till he'd fallen asleep to pop her dummy in so that she could sleep. But she was afraid to have a dummy on a ward, that people would think that there was something wrong with her and maybe they might involve social services or something. And so she didn't sleep for 2 nights because she didn't know how, and ended up having a bit of a breakdown on the ward, and social services got involved. And, you know, I'm not necessarily saying that a dummy would have been the difference, but if there had been a sort of prior plan and conversation, and, you know, it would just not be attended to and she would have permission to use a dummy, great. You know, it would have maybe made that difference there. Now, anyone who's heard me talk before is probably quite disappointed that I've not taught you anything about wildlife yet. So to correct that, here are some ants transporting ant larvae. And some species of ant, if the larva gets dropped or left behind, it will emit a squeaking sound. And the ants will respond to that auditory cue and go and collect the larva. These are gharials, which you might be able to perceive are riding on the head, most of them, of their mother. Gharials are a type of Indian reptile that are in the crocodile family, and like all members of the crocodile family, gharial mothers are very, very protective mothers. They will transport their young very tenderly in their mouths or on their back, and they will defend them as ferociously as you would expect a crocodile to. Crocodiles form some form of bond with their offspring. So when I hear professionals questioning whether an autistic woman will be able to bond with her baby because she is autistic, or professionals casting doubt on a putative diagnosis of autism because a woman is able to respond to her baby's cues, what I am hearing is that that person expects autistic people to have parenting instincts that are less well developed than literal mindless drones and cold-blooded murder machines. Being autistic does not predict an inability to bond with or take cues from one's baby, and bonding with your baby and taking cues from it does not go against the diagnosis of autism. You know, there are challenges that autistic parents will face that perhaps other you know, mothers won't face, but there are strengths that autistic mothers will have that perhaps other mothers aren't so likely to have. But, you know, one thing that is very much the case, my autistic patients bond with their babies, except the ones with severe postnatal depression, and they bond with their babies afterwards. Same with the non-autistic patients, or the ones who never wanted the baby and were pressured into keeping it. And again, same with my neurotypical patients, but otherwise they do bond with them. Very occasionally I will have autistic patients who say they struggle to read some of their baby's cues, but not, from my experience, at any more of a rate than non-autistic patients. And, you know, the couple of autistic patients that have said that have both responded well to VIG in that regard. And actually, both of them, the feedback from the VIG practitioner was that actually they were very good at responding to their baby's cues. They just didn't recognize that they were good at it. So that's my time up. I'll just leave my sort of key points up there for you to just take in for a moment, but then I will hand over to Jessica.
Thank you very much, Sam. I'm just getting my slides up. So hopefully you can all see my slides. I think Eloise will tell me if you can't. So I'm Dr. Jessica Gibson. I'm currently a consultant clinical lead in the adult ADHD service in Oxford, but also previously a perinatal psychiatrist. So all of these subjects are very close to my heart. And thank you for inviting me and for that really fascinating talk, Sam. And I feel that the subject of today's Grand Round is really timely. And we've all seen that issues relating to neurodiversity are increasingly in the media and coming to our attention in health services, but that people with neurodiversity have been overlooked and misunderstood for far too long. And what I'm hoping to do today is try and paint a picture of how ADHD presents in girls and women, so we know what to look out for in our antenatal clinics and our mental health services. Women and girls with ADHD will have had markedly different life experiences before we meet them in the perinatal setting. So it's important to understand how they may present and the specific challenges that they'll face with their pregnancies and the postpartum period. So I'm just trying to move my slide on. There we go. So this rather busy slide shows the main symptoms present in attention deficit hyperactivity disorder. And as you probably know, there are two main domains: inattentive symptoms and hyperactive impulsive symptoms. And in the inattentive domain, we find girls and women who struggle to get started with projects, maintain their attention for any length of time without becoming distracted. They struggle to organise their lives and work effectively and have poor motivation to attend to the basics of self-care and to remember important appointments and keep track of their personal belongings. In the hyperactive impulsive domain, we see women with huge amounts of restless energy to the point where they can't remain seated at school or at work, and they also have a great deal of internal restlessness and agitation, which means they can't relax and even sometimes can't sleep. They can be very chatty, and their impulsivity means that they may blurt things out without thinking, and that can cause real problems in their relationships. And in addition to these two domains, we see a significant amount of mood fluctuation, which can actually be mistaken for borderline personality traits. And women with ADHD may also be more likely to engage in risk-taking behaviours, which is obviously important around the perinatal period. So, in order to make the diagnosis of ADHD, we need there to be at least 5 symptoms present in either of the domains. If they're present in both, then it's a combined type of ADHD. And this is a neurodevelopmental disorder, so it starts in childhood, and we need to see evidence of this either by speaking to their family or seeing school reports. And the symptoms need to be present across different settings in life. So not just at work, but also impacting on their personal relationships, their ability to have hobbies, and importantly, their self-care. And then we need to see that the ADHD symptoms are severe enough to cause a significant impact on their functioning or well-being. So a woman with ADHD will have marked difficulties in her life. She may well struggle to get to work on time, to perform to her potential and maintain a job. She might find it hard to remain engaged with friends and family and to actually take care of her physical and mental health. And women with ADHD who are hyperactive often engage in riskier behaviours, spending money impulsively with poor budgeting, and they might drive unsafely with a higher rate of accidents. Living with ADHD is extremely stressful and causes a high level of mental illness. And when we meet women in our ADHD clinic for the first time, it's very likely they will already have been diagnosed with anxiety and depression, often with the treatments having been unsuccessful. Women may then seek other ways of managing their racing thoughts, restlessness, and low self-esteem, such as using substances. Yet, with all these difficulties, girls and women with ADHD are still under-recognised and underdiagnosed. So why is this? So I think my slides are just, yeah. So there are various different theories about this, but it seems that the long-held belief that ADHD was more prevalent in boys than girls by a factor of 4 to 1, which is what we all learnt in our training, is simply wrong. This is because the diagnostic tools we use have a strong bias towards boys with hyperactive externalizing presentations. They're the Tiggers in the classroom, causing disruption and getting into trouble. Also, the majority of ADHD literature has been written about boys and men. And it's this mistaken belief that ADHD is predominantly a behavioural disorder that has meant the quiet, inattentive, dreamy girls are being missed. And partly because these girls are being overlooked, they start to amass other mental health difficulties as a result of their undiagnosed ADHD. Ah, there's Tigger. I thought he was missing. So what we find is that by adulthood, both physical and mental comorbidities in women with ADHD is the rule, not the exception. The majority of adults with ADHD will have a comorbid mental health disorder, and quite often more than one. Females are more likely to internalize their difficulties, which leads to depression, anxiety, and emotional lability. And once these are diagnosed, they're thought to be the primary problem, and we don't look further for the actual underlying cause. Females with ADHD do also have more externalizing behaviours leading to trouble at school, such as detentions, exclusions, and involvement with the criminal justice system. And I now always think of ADHD when I assess a woman with a history of misbehaving in class. She might have been sent to a pupil referral unit or have a forensic history. And it doesn't stop there. We also see higher rates of self-harm and suicide in women with ADHD. Women with ADHD have higher rates of all eating disorders, including binge eating, probably due to impulsivity, and obesity, which might seem counterintuitive for this group of apparently hyperactive people. And being overweight is obviously significantly associated with poorer obstetric outcomes. There are also much higher rates of all substance misuse and an increased mortality rate. And women with ADHD don't just have a high rate of mental health difficulties, they have an increased risk of literally all physical health conditions apart from arthritis for some reason. Some of these are related to substance misuse, such as liver disease and COPD on the list, but there's now some fascinating new research that links hypermobility, chronic fatigue and autoimmune disease with both ASD and ADHD. And if you're interested, I really urge you to look at Dr. Jessica Eccles's work by searching @Bendy Brain. And one of the most shocking facts is that people with untreated ADHD die on average almost 13 years prematurely. So this is not an insignificant disorder. And it's important that we're aware of the marked comorbidity between ADHD and other neurodevelopmental conditions. So at least 30% of people with ADHD will also have ASD, and rates of all other learning difficulties, as well as motor disorders, are increased as well. So this slide highlights that girls and young women with ADHD will have faced many more life challenges than those without ADHD by the time they reach pregnancy. As we've seen, girls are less likely to be referred for an ADHD assessment, diagnosed and treated effectively than boys because of their internalising behaviours. At least partly as a result of this, they're likely to reach a lower level of academic attainment, to drop out of school younger and with fewer qualifications, which obviously leaves them in a very vulnerable situation. And the teenage years are obviously a time of high levels of impulsive behaviour for many young people, but especially so for those with hyperactivity and poor self-control. And we see that teenagers with ADHD become sexually active younger, they have a higher number of sexual partners, increased risk of STIs, and higher rates of teenage pregnancy. And so this is where they may begin their perinatal journey. And as adults, women with ADHD do less well in the workplace as well, and at home. They're more likely to be in low-paid jobs with insecure housing, and they experience higher rates of intimate partner violence and may have some real challenges with parenting. If you think about how much organisation and consistent focus it takes to attend all your antenatal appointments, help run a household, hold down a job, possibly whilst also taking care of a young family, you can see why many women with ADHD find the juggling of adult life almost impossible. And while there are many reasons why ADHD presents differently in women than in men, an important one is, perhaps not surprisingly, our hormones. So this is a little reminder slide for any of us who've forgotten our menstrual cycle. These two graphs show the fluctuations of hormones through the menstrual cycle and through pregnancy. And on the left, we have the menstrual cycle. And what I'd like to highlight here is the release of estrogen, which is the red line, which peaks at day 14, just before ovulation, and then falls quite dramatically, whilst the progesterone, which is the dark blue line, increases in the second half of the cycle, preparing for possible pregnancy. And on the right-hand side, we have pregnancy. And here the levels of estrogen and progesterone both increase until delivery, when they suddenly plummet. And as we know, in the immediate postpartum period, we see some of the most dramatic shifts in hormone levels, which are implicated in postpartum mental illness. So these hormones, sex hormones, are closely linked to executive function in the female brain. There's a real paucity of high quality research in this area. However, we do know that sex hormones interact with a wide range of neurotransmitters. The underlying brain neurobiology of ADHD is a deficit of both dopamine and noradrenaline in the brain. So in the frontal cortex, this causes difficulties with executive function, organization, planning, concentration, short-term memory, lack of distractibility. And in the motor cortex, this causes hyperactivity. Estrogen potentiates the action of dopamine and is therefore a driver for effective executive function. Low levels of estrogen therefore lead to less dopamine and poorer executive function. The role of progesterone is more complex, but higher levels are likely to be causal factors for emotional dysregulation and memory impairment, especially in the premenstrual phase. So if we transpose this onto the menstrual cycle, we see that as estrogen rises, executive function improves. And in the first part of the menstrual cycle, ADHD symptoms are at their lowest. And this is what patients tell us time and again in clinic. But as estrogen falls in the second half of the cycle and progesterone increases, we see an exacerbation of ADHD symptoms. This can sometimes be so severe that we prescribed an increased dose of stimulant medication in the premenstrual week. Higher levels of progesterone in the luteal phase, the second half of the cycle, may also increase impulsivity just when a woman is at her most fertile, which can be a perfect storm. So this now brings us into the perinatal period. And where will we see ADHD in our obstetric and mental health teams? Well, the answer is everywhere. The specific difficulties faced by women of childbearing age can be seen in the antenatal period and throughout the pregnancy, as well as the postpartum phase and parenting difficulties. And I'd like to take a moment to thank my friend and colleague, Dr. Manal El Maraghy, who's a perinatal consultant in Buckinghamshire, for letting me use and also tweak some of her slides from a presentation we gave together last year. So we've covered the antenatal period and we'll now have a look at pregnancy. There's some anecdotal evidence that women's ADHD symptoms actually improve in pregnancy, most likely due to the effects of rising estrogen. However, there's an increased risk of adverse pregnancy outcomes regardless of whether or not a woman is taking ADHD medication. And this is due to women with ADHD having more obstetric risk factors. These include significantly higher levels of substance misuse, smoking throughout the pregnancy, and extremes of weight. These difficulties highlight the importance of considering ADHD medication prior to pregnancy and possibly beyond. So this is all of ADHD treatment on one slide, which I've never presented before, but it does show that it's actually quite straightforward. On the left, we have stimulant medications, methylphenidate and dexamphetamine, which come in both long and short-acting preparations. These treat symptoms of ADHD by increasing the release and reducing the reuptake of dopamine and noradrenaline, which we saw earlier are key neurotransmitters for executive function and motor regulation. We also have two classes of non-stimulant medications. There's atomoxetine, which is a noradrenergic reuptake inhibitor, and the alpha agonists, guanfacine and clonidine. Importantly, there are several non-medication interventions, including therapies such as cognitive behavioral therapy, dialectical behavior therapy, as well as life skills such as diet and exercise. So one of the big questions for us is whether or not pregnant women should continue to take ADHD medication. Well, this is an increasingly common scenario as more women are prescribed stimulants and a significant number of pregnancies are unplanned. It's not unusual for a woman to be well into her first trimester on stimulant medication before she realises she's pregnant. And unfortunately, this is an area where we do not have clear guidelines due to the poor evidence base, because, of course, we can't conduct randomised controlled trials in pregnant and breastfeeding women. We do know a little more about the stimulants than the non-stimulant medications, and of course, the non-pharmacological treatments may well be the first choice in the perinatal period, if these can be accessed, although we know that provision is actually very patchy. So any decision to prescribe ADHD medication in pregnancy must be based on a very careful personalised risk assessment of the pros and cons of medication for that specific woman. We take into account the severity of her ADHD symptoms, her life circumstances, previous pregnancies and what happened in them, and postnatal experiences. What we do know is that the data on standard stimulant medications are actually largely reassuring. There are two excellent recent systematic reviews combining data from large cohorts, and both of them concluded that there was no clear association between the use of stimulant medications and a wide range of maternal and neonatal outcomes. There was in these studies some suggestion that the risks of exposure to methylphenidate in the first trimester was higher than with dexamphetamine. The risk was principally of cardiac malformation, and you'll see from the data that the actual risks are small, with an increase from the baseline risk of cardiac malformation. And of course, we have to remember that there is a baseline risk of congenital malformations. So that risk of cardiac malformation increases from 1.07% to 1.7%. With a number needed to harm of 159. For women with first trimester exposure to methylphenidate, therefore, it might be indicated to refer them for fetal echocardiography. And for this reason, lisdexamfetamine is my first choice and our usual first choice first-line stimulant in pregnancy. And how about ADHD medication and breastfeeding? Well, again, there are no controlled studies, but the risk of unwanted effects to a breastfed infant are possible. So medication should only be given if the potential benefit justifies the potential risk to the infant. And how do we gauge that risk? Well, we look at the relative infant dose of a drug, and if this is less than 10% of the maternal dose, then the drug is said to be safe to use during breastfeeding. So with lisdexamfetamine, around 5% is excreted in breast milk, so that's considered safe, and actually almost undetectable amounts of methylphenidate are excreted. We have less data for atomoxetine and alpha agonists, so we advise avoiding those in breastfeeding. And of course, there's a lot of evidence now of the benefits of breastfeeding, both emotional and physiological for mother and baby. And the risks of not breastfeeding may therefore outweigh the risks of using stimulants. If so, it's important to monitor the baby for potential negative effects such as irritability and poor sleeping patterns. And if we see these occurring, we can reduce the stimulant medication or advise the woman to consider stopping breastfeeding. It's always important to remember that if you have a preterm baby, they may not be able to metabolize ADHD medications effectively due to their relatively immature livers. So when we're trying to decide whether or not to continue ADHD medication into pregnancy and breastfeeding, we need to consider the risks of the medication against the risks of untreated ADHD. And I hope I've shown that the risks of medication are probably low, but actually the risks of untreated ADHD may be significant, and these include poor planning and organisation, poor attendance at health appointments, and that includes antenatal care. Their diet may be poor and there's chaotic behaviour. These women can be impulsive, risk takers, and there's a higher rate of drugs and alcohol throughout the pregnancy. And we also know about the comorbidities such as anxiety and depression, which themselves may then need pharmacological treatment. There may also be child protection concerns. So in the postnatal period, we've seen that the dramatic reduction in estrogen and progesterone are potential causes of postnatal depression, and that the ADHD brain is more sensitive to these hormonal changes. In the postnatal period, women are also dealing with an enormous life transition, and I've certainly seen women for whom ADHD presented severely for the first time postnatally. For women, their usual structures and supports fall away. Babies are a major multitasking challenge. Many women without ADHD note poorer cognitive function in this period, and in addition, we have the effects of sleep deprivation. So what happens in the real world? Well, we're unlikely to initiate a new treatment in pregnancy, especially the first trimester. And the more common scenario is that women conceive whilst taking stimulant medication, especially given the rates of unplanned pregnancy. However, we are able to stop stimulants abruptly as they have a short half-life and no weaning period is required. So if you can get through the first trimester when the heart is formed, that's a huge benefit. But we do increase if risks are significant. And Manal is there, so I'm just going to leave my last slide. These are some really excellent websites. Choice of medication you might be familiar with, but Bumps is a fantastic website for medications in pregnancy, and that's a patient-facing website. LactMed is for professionals and has lots of highly scientific information about drugs in breast milk. Thank you very much indeed.
Thank you very much. Thank you to Dr. Sam Porter and to Dr. Jessica Gibson for excellent talk. It's already people are thanking you because it has been really inspiring. I particularly liked the reference between the connection between the autistic mom and developing bonding with a child, and from Jessica, the connection between the hormonal change and the symptomatology of ADHD. Thank you ever so much. We will move on quickly to a very interesting second half of the webinar. So we'll watch together a video recording with a patient who suffered with neurodiversity presentation during the perinatal period, undiagnosed before that, and then it will be followed by a QI project presented by Dr. Shimrit Ziv and her team. So Shimrit is a consultant perinatal psychiatrist in Cambridgeshire with a background of practice in child and adolescence and working with the younger group of patients who had a diagnosis of neurodiversity. And she is joined by her CT, Dr. Dilara Yozgatli, who is very interested in working with in Fulbourn Hospital, and the doctor-to-be Libby Bryant, medical student, year 5. Can I just remind you that I noticed that on the chat there are a few questions, as well as a thank to the speaker. Please put the question on the queue and answer, and Dr. Porter already started to answer some of them, and I guess Dr. Gibson will do. Over to you, Shimrit will start by the video. Thank you very much.
Hello, I'm Dr. Shimrit Ziv. I'm a consultant child and adolescent psychiatrist and a perinatal psychiatrist. I work in Cambridge in the community perinatal mental health team. And I'm delighted to introduce Sami and to interview them today about their journey in the perinatal mental health team and through the assessment of the ADHD and ASD diagnosis. It's an incredible personal story, and Sami is a mother of twin daughters who were born prematurely. So I'm extremely grateful for them to join us and enable other moms to listen and enable other professionals like me to learn from their story, hopefully helping other moms. And so thank you so much for agreeing to join and share your story. So Sami, I understand that you were referred to our team, to the perinatal mental health team, already in pregnancy due to emotional difficulties and anxiety. Would you be able to tell us a little bit about that?
Initially, it was the mental health team for midwives, which is the Juno team at Addenbrooke's. My midwife Selena made a suggestion of potentially having support after the twins had been born, because I struggle quite a lot regulating and speaking and doing things in general anyway. And I was very reluctant to be put forward for the perinatal team, but once I was very welcomed with open arms, very supported, especially by you. And it felt like I'd finally found a little piece of help from the NHS that was actually going to do something for me.
Oh my God, that's so nice to hear. And can you tell me also what personally led you to think you might be struggle with neurodiversity and to seek for ADHD and or ASD assessment?
So I was diagnosed with borderline personality disorder in 2019, and from the moment I was given that diagnosis, I knew it was incorrect. It didn't sit properly. I didn't know how to dispute it. I didn't know how to do anything about it. So I kind of just shrugged my shoulders and got on with it. But I knew that something wasn't quite right, and I wasn't quite like everybody else that I spent time with, because I'd find things like socializing very difficult, leaving the house in general very difficult, and I seem to surround myself with other neurotypical people or neurodivergent people. It tends to be neurodivergent people because I've always found a safety in other neurodivergent people, but my friends suggested. Yeah, a couple of people suggested it to me, friend-wise, that also have diagnoses of ADHD and autism. And then I questioned myself about it, researched, and thought, well, okay, well, maybe this is something, and decided to mention it to you and see what you could do or thought about it.
Thank you so much for sharing that. And tell me, it sounds that your difficulties were attributed to emotional dysregulation rather than neurodiversity. And I wonder, particularly, how did you find the assessment process of the ADHD? In what way did it help you?
The ADHD, when we sat down and went through all of the questions and stuff, it was quite an easygoing questionnaire that you had to fill out, and it wasn't too draining. It was just a nice conversation, a couple of questions, and then a decision's made at the end. But it was, luckily for me, quite a quick process going through the perinatal team, which I'm really grateful for, because otherwise I would have been sat here for years not knowing what was wrong.
I remember when I did send the forms prior to the proper assessment, which we did by video, right? Yeah. And I remember you were a little bit hesitant or anxious about completing the forms, right? Can you tell me a little bit about that? Is it like in general something you worry about?
Looking at forms in general, if I have to fill it out by myself, I leave it until I literally have about an hour until it has to go back to where it needs to go, because looking at the bit of paper and the questions that are on that bit of paper, it's very scary. And when you're reading the question, I never know if I'm understanding the correct question, or if I'm taking the question in a different way and I'm answering it incorrectly, and it's easier to put it off than to try and deal with it and get overstimulated and overworked and stressed about it.
I see. And it's something you have mentioned a lot of times to me during the appointment as well. And how did you find the actual conversation, and did it make sense to you?
When it's a verbal conversation, not a written, I have to read things and respond to it via paper, I find it a bit easier, because I can read the tone of voice that the person's using. I can ask the question of, could you just explain that in a different way, because I don't really understand. But looking at a bit of paper, obviously it's black and white, you can't change it, you can't ask questions, and it's very stressful compared to talking to an actual person and saying, look, I don't understand what you're saying, could you just re-explain it?
And then we have referred you to an autism assessment within our trust, but this was not done specifically by the perinatal mental health team. Could you tell me a little bit about this process and how have you found it?
I can't remember with the class clinic that I had. So when you put the initial referral through, they were quite quick to get in contact to set up an initial conversation, like sort of what's going on, what do you need from us, what do you want to come out of this, and then it was a couple of weeks, and then I heard from them again about an appointment, which was a 3 to 4 hour conversation about my childhood, about my experiences in childhood, in school, in adolescence, in adulthood. It was quite a relaxed conversation. It wasn't what I was expecting at all. I was expecting a very formal, like very formal questions and having to give a very formal response, but instead it was professional led, which I really appreciated because I'm not very good at just speaking. But the questions that she asked were very, if I didn't understand and I asked to explain, she'd really explain. But the conversation itself was quite relaxed. It was quite nice. It was a bit daunting getting there and going in, but once you're in, you're sat down. It's not as scary as you think, I guess.
And have you found it helpful having the diagnosis, having the assessment?
I now understand why my brain works in certain ways, whereas others don't. But I'm still working with them to understand the diagnosis itself and how I can maneuver life now with that diagnosis. But it helps me to understand that I do need to be that little bit more patient with myself, and I do need to look after myself that little bit more, because my brain's slightly different to everyone else's, and I just need that little bit more time and care.
Sounds like you're more forgiving to yourself, and it may have helped you to understand better your needs and also make sense of them.
Yeah.
And can you tell me a little bit about your struggles, difficulties, and successes being a mom with neurodiversity, having both ADHD and autism, and mom to 2 twins who were born premature?
It's definitely been challenging, to say the least. I look at my little girls and see the world, and I know that every mum will always say that, but when I look at them, I see a little piece of me, and it just makes me like that little bit more. I've got to look after you, I've got to take care of you. And I've noticed that other mums, if you're walking through city centre, for example, and there's another mum with a baby in a buggy, and some random person goes to touch the baby, the mum's not gonna respond and go, get off my baby, don't touch my baby. Whereas me, because of the way that my brain functions, if someone's to touch my child that I don't know, I start screaming at them, telling them to get the fuck away from my, sorry, excuse my language, I start screaming at them, telling them to get away from my buggy, not to touch my children without permission. And the other mums just sort of look at me like I'm crazy. But it's that extra, like, the emotions are bigger in general anyway because of the other diagnoses along the ASD and the ADHD. But those emotions are bigger and they're harder to control, especially when it comes down to my children. And they are the things, they are the people that I will die for. I wouldn't kill for them, but I would die for them. And the understanding of the reason that I have this particular need of control of what's going on around them and how to protect them is because no one ever protected me as a child, and now I understand why no one was able to protect me. I know that I can protect my children by doing the opposite of what everyone else did for me.
I understand.
And it's just that big feeling that's so, it just drowns you. But it's always, every emotion's like that. But it's easier to understand when you actually have the diagnosis on board to know why and how it happens.
That's so helpful. And through your journey, I just need to say that I have found that you react a little bit more subtle in your emotions than in the when we first met, and also allow people to engage with you more. I have to say that it's been a major struggle, hasn't it?
Yeah.
And so I'm really grateful.
I think engaging has always been my biggest issue, because it's very difficult when you're jumping left, right and centre from professionals, because when you get happy and settled with a professional, your time comes to an end and then you'll jump into the next one, which is what I liked about the perinatal team so much, is the fact that you're there for a year and it's set in stone that you are there for that amount of time. So I personally was able to prepare myself for that discharge and be like, right, I'm being discharged in X amount of weeks. I'm prepared for this. But deep down, I don't think I was actually prepared for it. But it made it that little bit easier to be like, okay, I now know what's wrong. I know now that I have select ways that I can deal with issues that are more positive than the ways I used to. And that there is still people there that are willing to help. You just have to find the right professional.
Oh, that's so nice to hear. Thank you so much. We are now out of time. It's been really, really, really nice to hear you today, and I'm really grateful for you sharing your journey with us. Thank you.
Could we have the presentation? So hello everyone. Is it just a minute? I'll wait. I can't see the slides.
I'm just bringing them up. Sorry, just one moment.
Good, brilliant. So thank you so much for Sami, who shared their story. And in addition to the interview, I'd like to share with you a service evaluation quality improvement project that has started to run in our team. I'm a consultant child and adolescent psychiatrist and a perinatal psychiatrist working in Cambridge. And I'm very, very pleased to have two doctors joining me today who have helped me with this project. We will start first with Dr. Libby Bryant, a little bit background and rationale for this project, and then we will hear from Dr. Dilara Yozgatli about the current challenges in the service seeing patients with ADHD, and then you'll hear from myself about the actual project. So starting with Libby.
Yes, if we could get the next slide, please. Perfect. So yeah, I just wanted to start by providing a brief background as to what the current literature is telling us about the impact of untreated ADHD during the perinatal period, and kind of the motivation for why we're doing this QI project. So firstly, there was this big systematic review by Sarah Kissel-Schneider et al. That looked at maternal ADHD symptoms and their effects on parent-child interactions. So they had lots of findings, including increased parental stress, increased risk for ADHD development in children, more lax and overreactive parenting, high levels of chaos in the household, and also increased aggression in children. They also produced this schema that you can see on the right, which I thought was quite interesting, showing the multifactorial influence of perinatal ADHD during pregnancy. So you can see a a little bit of what Jessica was mentioning as well about unhealthy behaviours in pregnancy and birth complications, as well as the impacts of maternal ADHD during the early infancy, as well as paternal ADHD. I thought that was quite interesting as well, although beyond the scope of this project. Next slide, please. So further research also found maternal ADHD was associated with insensitivity and intrusiveness in play-based interaction, harsh responses to children's negative emotions when they were observed, child ADHD symptom and lower quality of life in the children as reported by their mothers, and as well as children going on to develop ADHD and also ODD, thought to be due to this disruption in parenting. So although that was very brief, hopefully it's illustrated a little bit of background as to why we're doing this project. And I'll now hand over to Dilara, who will discuss a little bit more about the project aims.
Thank you, Libby. I believe as around 400 people here, we are quite passionate about diagnosing and treating women who struggle with mental health during the perinatal period, because this is such a short period which can be extremely stressful and cause adverse outcomes if these patients are not treated timely. Now, if you could go to the next slide, please. I'll go through the current practice in our trust and just walk you through what the patient is offered in our services currently. So a patient can be referred to our services via a GP, a midwife, or a health visitor if they feel that these patients need secondary care intervention. So when they are referred, there's a referral meeting to see whether the patient meets the criteria for treatment, like assessment and treatment with the perinatal mental health team. And if this is met, then we assess these patients using one or more of the tools that are mentioned here in the outcome measures. And then we have a formulation meeting where we discuss all the protective factors, predisposing factors, and how we can help this patient during the perinatal period. So the intervention can be in the form of peer support, it can be in the form of psychoeducation, it can be via a psychiatrist and some medications, or if it's a complex case, we may assign a care coordinator and liaise with other services, or it can be in the form of supporting the kid if the baby is born with a nursery nurse or additional nursing support. Next slide, please. Thank you. So after this perinatal mental health team intervention, in the event that the mother has symptoms of ADHD and we do not see any improvement, then there's another meeting. So this is a meeting usually where we discuss what we call the red and purple cases, meaning these are high-risk cases which pose a danger to either the mother or the baby in the long run if the mental health difficulties go untreated. So if the history is suggestive of ADHD, we make a referral to the ADHD clinic, but there are several downsides to that. The first one is the perinatal ADHD wait time is sometimes around more than 5 years. So we miss this invaluable time period, the perinatal period, where the mother, the pregnant lady, the mother, and the baby needs our support or the treatment the most. And secondly, as our patient mentioned in the interview, the patient has already made contact with our services, they got used to all the mental health team, and then a transition to a different service would come with additional adverse outcomes. And for these reasons, we came up with this service evaluation project, which Dr. Shimrit Ziv will talk about in detail now.
Next slide, please. Thank you both, Libby and Dilara. So what are we trying to achieve actually? So we want to provide assessment which is specific to those women with suspected ADHD in the perinatal mental health service, and to provide both intervention and assessment, and the intervention specifically by psychoeducation and consider medication. We would like to measure the outcome with outcome measures before and after the assessment and intervention process. And in order to this be achievable, we have to pick up those women who struggled with normal intervention, with standard intervention, and have had no improvement or no sufficient improvement with standard perinatal mental health intervention, and those women who have highly suggested symptoms of ADHD. Is it relevant? ADHD is common, at least in 5% of adult population, and probably much higher percent in psychiatric patients. And as we heard in previous presentation, and also from Libby, maternal ADHD impacts both the mother and child and their interaction. And we are trying to achieve a timely assessment and intervention pathway within 1 year postpartum. Next slide, please. So how are we going to achieve it in practice? How is it going to look? So those mothers under the perinatal mental health with no improvement to standard intervention and a history of ADHD, highly suggestive of ADHD, those we will screen them by delivering the BARS questionnaires. So the BARS questionnaire is actually a questionnaire that is specific for the adult with ADHD and is rated both by the adult and others. And it is aiming to look at symptoms not only at present, but also in childhood. Only if the symptoms are scored as highly suggestive of ADHD, then we will carry the DIVA structured interview. This is a structured interview that has to be delivered by a skilled clinician in order not to do overdiagnosis. So the way we do it is usually by a trained clinician, and by as much as possible open-ended question, and we have to listen to the story and to look for specific examples of ADHD symptoms. Only then, if it's still highly suggestive of ADHD, we will move up to the next stage, which is intervention, treatment, and we offer psychoeducation session and consider medication if needed. Following a period of 6 to 12 months, we are aiming to repeat the psychiatric review, repeat the DIVA, and repeat outcome measures. Next slide, please. We also have some future plans to extend this into a research project in order to answer the following research question. So how big is the problem? We want to carry out a systematic review to define the prevalence of ADHD diagnosis in young mothers, and to make a survey of perinatal services to look and to learn the number of perinatal ADHD seen in the last 6 months. We want to answer the question, what is the experience of those mothers, those young mothers facing ADHD, and that's via qualitative interviews and focus group. And what might we do about it? How can we help those mothers? And what is already available for those mothers? And also potentially to carry out economic modeling, to consider acceptability, to understand the cost of society of maternal ADHD. So these are our plans. Next slide. And I wanted to thank many people. First of all, Sami, who agreed that I could obviously interview them. and also Dr. Nicolette Kabaj, who is my colleague at the Cambridge Perinatal Mental Health Team, and Dr. Alexandra Luis, who I believe you're here today, who helped me so much with the ideas, and a lot of other people who inspired me, Dr. Green and Meisner Stedman and Professor Nandini, of course, and Professor Helen Minnis and Professor Tamsin Ford for the amazing ideas about research. So thank you so much for this opportunity.
Thank you very much, Shimrit and the team. It's impressive that the year 5 medical student from Cambridge University has summarized it in a couple of slides. Thank you very much, as well as the interest in your team, inspired by you, I guess. There are a lot of questions in the Q and answer, and Dr. Porter and Dr. Gibson started to respond. I just want to reassure everyone that the recording will be circulated, including the interview with a patient. And thank you very much, Shimrit, for recording it. It's really good. So if I go by the question, there is a question about the correlation between polycystic ovaries and endometriosis with ASD. And other psychiatric disorder. Does any of the panelists know the answer? I'm not sure if even there is a research in this area.
No, so there is research on the link with endometriosis and polycystic ovaries. I may have put a link in my slides. I may have forgotten, but there is research. I don't know about links between polycystic ovaries and other mental health, well, with mental health problems and polycystic ovaries. No.
Sorry, Sam. There are higher rates of endometriosis in ADHD, and there's definitely a link with inflammatory disorders, chronic pain, autoimmune disorders. Not that endometriosis is autoimmune, but women with ADHD often have very significant premenstrual dysphoria and a higher rate of endometriosis. I don't think we understand why yet.
And I think that links into the fact that hasn't really come up yet, but it was so explicitly, but autism and ADHD coexist as often as they exist separately. And actually, not only that, but I see a lot of ADHD women who will have lots of restricted and repetitive behaviors and interests. They don't have the social aspects of autism, but they will have special interests or, routines and rituals and things, sensory sensitivities. But yeah, there is a sort of overlap. I just wanted quickly, if I may,
yeah, please.
I never used the expression ASD in my talk, and I would normally explain why, but we were quite pressed for time. But I just noticed that ASD is all I've seen in the chat. It's actually NHS England guidance not to use ASD, but to say autism. That is NHS England guidance. And I just want to sort of slightly address, there's things in the comments, and I don't want to be too explicit about things and embarrassing individuals or whatever, but how can we improve autistic people's communication or bonds? How can we get them to do it better? Like I said, I'm trying not to be too, but a sort of assumption that autism is the broken state and neurotypical is the superior state. Autistic people communicate with each other more effectively than neurotypical people communicate with each other. Autistics are actually better at communicating. It's just that there are fewer autistic people than non-autistic people. It's when communication is between autistic and non-autistic people that communication is terrible. and because the majority think, well, they're the ones who are wrong. So, you know, but actually autistic to autistic information transfer is more effective and more efficient than non-autistic to non-autistic. The autistic way is not the wrong way, and we don't need to fix people having autistic traits. There was a study done that showed that autistic people were less likely to accept money to be complicit with illegal activities. And the researchers' conclusion was that deficits in autistic theory of mind led to autistic people to give undue consideration to the moral cost of their behavior. How can a deficit in the ability to take someone else's perspective lead you to take an undue consideration to the effect that your actions have on others? They essentially said that autistics had deficits in moral flexibility. I think that was the expression that they used. Because if you start from the position of ASD, if you start from the position of this is a disorder, then you have to contort, you know, things like that and say that is a deficit of theory of mind. You know, autistic people face a lot of challenges, and I'm not diminishing that, but we don't have to fix their autisticness. I'll step down from my soapbox.
Thank you very much. I appreciate the comment, and it's very useful. And I agree that we should say the person with autism and rather than the ASD. Thank you for the further elaboration. If we go down to some of the questions as much as time allows, and I want to reassure the audience that will be some summary for the question and answer to be shared later if we can't answer all of them later on. At the moment, I mean. So there is a question to Jessica. Hello, is immediate release formulation of methylphenidate lisdexamfetamine preferable during pregnancy to the XL form?
Not necessarily, because you actually can get higher peaks and troughs. So actually, slow release it is often preferable, and certainly lisdexamfetamine is the one that we would start with in pregnancy, which is actually the longest acting, and also people forget to take their short acting regularly, so yeah, not necessarily. We wouldn't necessarily start with short acting.
Thank you very much. Another question for you, Jessica. Are there any studies or data looking into I'm sorry, I'm using what is written, or say autistic ADHD moms learning to bond differently, better than during their subsequent postnatal period? I'm wondering whether being eldest, youngest kid to a person with comparing neurotypical to autistic mother would be significant factor. And I know Sam answered some of it, say that we don't want to change, but talking about the ADHD.
Yeah, I saw that question. It's quite a complicated question and interesting question. And I think if I've understood correctly that the idea was that with subsequent pregnancies, more skills are learned. And so there might be closer bonding between a mum with ADHD and the youngest child. I don't know if I understood that correctly. I don't know of any studies, it's the short answer, but perinatal services, and Sam was talking about this with their sort of videoing, their big opportunities to actually look at how mums and babies are interacting is such a fantastic intervention. And I think that's the obvious place to start if the mum and baby are having bonding issues, or there's postnatal depression, and certainly issues like inattentiveness and perhaps not being able to hold the gaze and focus intently on the infant can be addressed through that. I don't know if that helps answer your question, and I'm not aware of studies that you asked about. Sam might want to add something there.
Do you want to add anything, Sam?
They're not off the top of my head.
Thank you. So I just, it's kind of a question and an experience shared on the question and answer. A colleague described herself as someone who has autism and ADHD and senior doctor, saying, I always knew I was different, but not what it was. I knew I'd be told an anxiety, depression, personality, but knew that it wasn't right. Dealing with healthcare service, even as a successful working doctor, has felt like having to hide my real self to get decent care. I will be hugely relieved when my children get to 18 and the risk of me being unfairly blamed by service for anything ends. Is there a way to hide or play the game?
If you are not, do feel free to get in touch with us at Autistic Doctors International, whoever you are. We're a community of nearly 1,000 doctors, maybe more than 1,000 worldwide, and do a lot of work in research, advocacy, and peer support.
Thank you very much. And on Twitter as well. I would suggest that you follow Dr. Porter on Twitter, and he may direct you there. Open-ended question, are they good for people who have both autism and ADHD? And the question is ADI, our question, our most close question.
Sorry.
So I guess the question
There
is,
is the question again.
I think it's about using open-ended question. Are they
Yes.
better for people who have both autism and ADHD?
I see. So I would say the reason why I said open-ended question, so there is another question. So we want to avoid as much as possible over-diagnosis because we want to make the right diagnosis to those people who really struggle and need the assessment and intervention, and not to those maybe people who want to achieve a little bit better in their life, and it's not a true disorder, because at the end of the day, we are a service, secondary care mental health service, and we want to help those who really struggle in functioning. Hence, the question should not be always closed-ended, because then it's like a tick box. So people could download questionnaires, ADHD questionnaires, and come already prepared. So we don't want to assess those who really seek the diagnosis. We want to assess those who have struggled in life, in functioning, may have also struggles in organization that impact their bonding and attachment with their babies, children, and it might cause further transgenerational trauma because of this attachment difficulties. Those are the ones we would speak about. And obviously, some mentioned as much as empathic and sympathetic and listening to the patient and try to modify our communication to the patient's needs, whether they're autistic, whether they are depressed, whether they have got ADHD. So we will try by any means to do that sensitively.
Thank you very much, Shimrit. Time is ticking, so we'll probably come to a close. Thanks to all the answers on the chat, and sorry if we can't all say all of them, but I want to take my position opportunity and ask Shimrit. So when there is an ADHD service, the plan and the commissioning is about the prescription come from the service. So with your project, are you taking into account to take some of that? How are you going to prescribe?
So this is a very, very good question, and there is a difficulty about the prescription. The main focus of this project is not just on medication, is also about the assessment. We would like to consider medication as well for those women who really struggle and need that as a life-changing method. And I'm just saying, again, ADHD may be common and may be a problem for a lot of people, but it's a massive problem for those who really struggle with ADHD. It impacts the entire family and the attachment and the future of those children. So if we do need to prescribe a medication, we will do it sensibly. And what we are able to do is to follow up these ladies for 2 years and possibly refer them to the adult ADHD clinic. But I'm very lucky to have received some consideration from the trust for additional PAs to follow up these ladies. So we will definitely form a shared care agreement with the GPs, so they are able to prescribe, and then we will only be we will need to follow them up annually, like the NICE guidelines. So this is more or less the plan, and we have started kind of a little bit. Hopefully it's going to work.
Excellent, excellent. Thank you very much, and good luck with your project. And it will be good that we hear about it in the future. I will stop there. And Dr. and Deepa, are you there? Please come in.
Thank you, Manal. I think that was, there's no doubt, was a fantastic session, an excellent learning opportunity there, as is evident from the chat and the questions and the discussion. So I would like to take a few minutes to thank everyone who's been involved in organizing these fantastic grand rounds. So thank you, Manal, for leading and chairing this session. So thank you to all the speakers and the service user who shared that really powerful personal account of their journey in the perinatal period. So please take a few minutes. There's a link to the feedback form in the chat, so please try and fill that. We continuously learn from the feedback, and we strive to improve these sessions from the feedback that we get. Thank you, Subodh. Thank you, Rav. And the fantastic, amazing Calc team members without whom this session would not have been possible. And finally, thank you to all the delegates who've joined us from all over the world, you know, for their active participation. And we look forward to seeing many of you in our next session of Grand Rounds. So thank you.
Thank you, Deepa. Thank you for everyone. Thank you.